The value proposition for the nursing knowledge information models, the what and the why, we'd be remiss by not starting with Florence, and her often quoted 1863 work where she bemoaned the fact that we have, at that time, challenges with data and telling the story of practice by meaningful data. And it's now in the 200th year of the nurse and the midwife, and we continue to strive to realize the concerns penned by Florence in 1863. The lack of data wasn't at that time fit for analysis, and frankly, I think we've even heard this morning in the earlier sessions some appreciative awareness that we're still on that journey. NANDA was the first standard for nursing diagnosis, developed in '73, and Omaha followed in '75 with representing nursing diagnoses, interventions, and classifications. And then ANIA began to recognize the terminologies and classifications in '92, and currently has a list of 12. So it's no wonder that nursing operations practice leaders are a little daunted by trying to come up with structured ways to create interoperability. So both Mary and I were devotees of Dr. Lang, Norma Lang, who was among the nursing informaticists, nursing quality and translational research pioneers who called to action over 30 years ago. If you can't name it, you can't control it, finance it, research it, teach it, or put it into public policy. So we're still in that journey. The ANIA position statement is inclusive of recognized terminologies supporting practice throughout the EHR or within the EHR and other health information technology solutions. So we've gained momentum by having these as position standards for our organization, professional organization. And there are 7 interface terminologies recognized by nursing, SNOMED, CT, and LOINC, of course, being the foundational ones. The nursing information, though, needs to be part of the health information exchange and digital transformation. DeSalvo, when she was at ONC, was quoted as saying, the exchange of information between health systems is flowing faster than ever before, and new technology innovations are bringing more usable digital health information to the bedside and beyond. We must build upon the success to create an open, person-centered health IT infrastructure that can support our neighbors, not just as engaged patients, but as healthy citizens across our lifespan. The Nursing Knowledge Big Data Science Project was initiated in 2013 with a core group of 40 members, invitation only, convened by dean and faculty at the University of Minnesota School of Nursing, Dr. Connie Delaney and Bonnie Westra, with a goal to develop a national action plan for shareable and comparable nurse-sensitive data. It hosts and we participate in faithfully annual conferences since then and year-round work group efforts. The vision of the Nursing Big Data Initiative is to better health outcomes, I should say, from standardization and integration of the care information that nurses gather in the health record. And the EHR is increasingly as a source of insights and evidence used to prevent, diagnose, treat, and evaluate health conditions. And finally, recognizing that the EHR provides rich contextual data about patients, including environments, geographical, behavioral, imaging, and much more, which will lead to breakthroughs for the health of individuals, communities, and populations. The nursing informatics practice, of which we're all aspirational and at various points in our journey, but It integrates the nursing science with multiple information and analytic sciences to identify, define, manage, and communicate data, information, knowledge, and wisdom in nursing practice. It's one of the things that we are, I think, the most central in helping champion, which is understanding the nursing process, workflows, and the integration of user heuristics, as well as the components of decision-making that promote not just data integrity and exchange of health information, but bring new insights and practice wisdom. So one of our anchoring frameworks, of course, is the data, information, knowledge, and wisdom model. This is an updated version from Nelson, from whom we did get permission to share. And finally, why is an information model important? It's essential that we build on intelligent nursing information systems that are actionable, that synthesize nursing data into meaningful care components for assessment, interventions, and outcomes, and that maximize the use of nursing data for electronic health records. The design of the intelligent information systems in daily nursing practice, as Dr. Lang noted in 2008, is the promise of simultaneously transforming practice and research, and a promise that we're still on the journey for, and which is really an anchoring objective and commitment from the nursing knowledge modeling work group that you're going to hear a lot more about. The nursing knowledge information model matters first and foremost because it provides the data systems with access to standardized nurse-derived data. It improves the effective evaluation of a link between care delivery and outcomes. It informs practice, education, and research, and it can be mapped to the EHR data to identify semantic similarities, as well as enable researchers to understand and normalize differences when they occur and improve data sharing. The current work, as was mentioned this morning, I believe it was by Dr. McBride, is that there are clinical information models in our universe, if you will. These are databases that are shareable content. They focus on, although unfortunately, the medical domain. The common data models include, I'm sure which we're all familiar with, PCORI's common data model. That's probably one of the larger, most popular ones, or familiar ones, and yet the information within it lacks nursing-sensitive information. So the majority of the EHR data models focus on medical management. The nursing diagnostic data is not reflected in these structured data sets. The gaps that limit interoperability are many. They include the EHR containing locally coded content, the point-of-care nursing data not being coded or not comprehensively coded, that there are no standard codes for orders, there's no process for converting local or ANA-recognized terminologies into SNOMED and LOINC, and it is very often not structured, standardized content, and those are among the many limitations. The standardized benefits, however, of having data is that we can measure the contributions, we can support the value of nursing assessment or measurement, and we can enable many things, including electronic clinical quality measures, enhance care coordination across the continuum, enable cross-institutional nurse-sensitive outcomes, studies, and quality improvement initiatives, and bring value to reuse instead of reinventing, including clinical decision support, AI, and MI.